Today, Kaylee, our first patient is Sarah, who I saw about a month ago. Yes, right about 4 weeks. So Sarah Smith is a 38-year-old female, white, with a medical history of a motor vehicular accident 2 years ago, resulting in a right broken clavicle, now healed. She also underwent recent dental surgery with 4 wisdom teeth extractions about 6 weeks ago. So what else do we know about Sarah?
Psychosocial history includes the patient is married with a 13-year-old daughter and a 3-year-old son. She earned an associate's degree in healthcare administration and is employed full-time as an administrative assistant at a local healthcare facility. She uses alcohol intermittently on a social basis. She was strongly encouraged to follow up with her oral surgeon to rule out a post-surgical infection. Her other chief complaint was nausea, and follow-up tests were negative for pregnancy. She also admitted to taking hydrocodone, 325 milligrams every 6 hours as prescribed by her oral surgeon, but when this prescription ran out, she found oxycodone, 10 milligrams that had been prescribed 2 years ago, post-motor vehicular accident, and decided to take that as well. Today, the patient is complaining about flu-like symptoms for the past few days, a febrile, and all of the tests have concluded there's no infection, so we just need to figure out what's causing her symptoms.
Great summary. You ready? Let's see Sarah. Hi, Sarah. Hi. I want to introduce you to Kaylee. She's a family nurse practitioner student. Is it okay if she joins us today? She's going to help with the assessment.
I guess so. I just really need to be seen. Excuse the language, but I feel like crap.
Oh, I'm sorry you don't feel well. We've run tests to rule out other medical conditions such as pregnancy and possible infection. So now I'd like to explore with you other possible causes of your symptoms. My MA said that you are feeling like you have the flu. So tell me more about that. What kinds of symptoms are you experiencing?
Like the flu. I feel achy, sick to my stomach. I can't sleep. My nose won't quit running, and I just hurt.
That sounds awful. I mean, you must feel terrible. I was wondering if I could ask some more specific questions about your follow-up session from last time. Are you still experiencing pain?
Yes. My pain is pretty generalized, but like I said last time I saw you, I have to work and keep the household going. I have 2 kids. I need something to keep me going.
Wow. Well, I know you said that you were feeling bad related to your wisdom tooth extraction. Were you able to follow up with your oral surgeon?
So, no. I did not follow up with my surgeon. But it's okay, because my mouth doesn't hurt anymore. It just hurts all over. But I haven't missed any more work, and the kids are still in sports and gymnastics, so, guess who their chauffeur is.
Wow, it seems like that's a lot to manage right now, and maybe taking a toll on you. How are you treating your pain and your pain control?
Not well. I may as well be honest. I've continued to use opioids. I know I shouldn't, but I just couldn't stop.
Thank you for sharing this information with me and for trusting me with it. I'm here to support you, and I can see that this isn't easy for you. Would it be okay if we continue this conversation about the opioids? I mean, it's very important for me to know as we plan our next steps.
I do trust you. There aren't a lot of people that I do, but I do know things aren't going well for me. Like I said, I did not follow up with Dr. Thompson, who took my wisdom teeth out, but I did go to a few emergency rooms to see if I could get some pain relief. I am still in pain, and like I said, I feel like now I'm coming down with the flu, but I'm sorry, I have to take this.
Sure.
Hey, honey. What's up? Yeah, you called twice. Everything okay?
Uh-huh.
Yeah, tell him he can't have a Pop-Tart right now. I'll be home soon to make dinner. Okay, where's your dad? Mm-hmm. Yep, go find Daddy. Yeah, and I'll see you soon, okay? All right. I love you too. Okay, bye. I'm sorry about that.
No, it's fine. Would this be a good time for us to continue, or do you need a moment?
Oh, no.
Okay, well, while you were on your call, I was able to use an electronic tool that tells us about certain prescriptions that are written for patients across healthcare facilities. It's called the Prescription Drug Monitoring Program, or PDMP, and it's integrated into our health records. So, just as you disclosed, you've been seen by 3 ERs in the past few weeks and been given several prescriptions for opioids.
I'm trying to be honest with you. I mean, I'm out of meds, and I took the last pill early yesterday afternoon. Oh, I'm so ashamed. Oh, I feel so lost. But I came to you for help, and I was honest. You're the only one who seems to care. Can you help me?
I appreciate your honesty, and I can sense this is not an easy conversation for you. But you've taken the first step to getting the care that you need. Okay, to help me get a clear picture, I have just a few more questions I'd like to ask you, but would that be all right? Okay. Help me better understand your opioid use. How would you like for things to be different?
I hate having to seek them out through the ERs. I mean, it's humiliating, but I just can't stop.
It sounds like you have an addiction to opioids.
It also sounds like you are conflicted about goals and doing things that may not be healthy or sustainable. It sounds like you are taking opioids and you want to stop taking opioids. And you're here to get the help that you need. Okay. What would you lose if you were to change? That is, stop taking opioids.
I'm really worried about feeling sick and not being able to take care of my kids or keep up with work. I feel really awful when I try to stop.
Those are real things to consider. So what would you gain if you were able to stop taking opioids?
Freedom. My health back. Not having to cover things up from my husband or hide things from my kids.
So if you were to decide to change, to stop taking opioids, how committed would you be to a plan of change?
If I could feel better, not have to worry about feeling lousy from going off opioids, I would be in 100%.
Okay. So it sounds like your goals right now are to feel better and to get your freedom back. I mean, those sound very important to you. And we're here to support you through that. I'll do a thorough assessment, mainly questions and a few more tests, and then based on that, we'll make a plan. Okay, I believe there are things we can do.
I'm really grateful to hear that. I do have to tell you, I have been taking oxycodone since my accident 2 years ago on a regular basis. It started as a way to manage my pain, but honestly, I just feel better.
Wow, it takes a lot of courage to tell us that.
Well, it gets worse. I've been getting it from whoever or wherever I can. I mean, coworkers, my in-laws, friends.
You must feel very tired from hiding. Thank you for sharing this information. It's very important for me to know this.
And it's ironic, you know, I try to be responsible since I work in a healthcare clinic. So I carry Narcan spray with me just in case anyone finds me or I feel too drowsy. I know how to give it.
I'm so glad you do that. Let's make a plan. I mean, that is, if you're ready for that.
I'm so ready.
There. Now, what questions do you have for me regarding Sarah's assessment and plan?
Well, the bupe prescribing is pretty complicated.
It can seem that way. Let's review it. And remember, it's based on the patient's symptoms. We're trying to reduce their discomfort, both physical and psychological. Experiencing the symptoms of opioid withdrawal is both physically difficult and scary. On day 1, we instruct the patient to take 2 to 4 milligram tab sublingually until fully dissolved. Wait 45 minutes. If they still feel sick, we can have them take another 2 to 4 milligrams and wait a bit longer, 2 hours. They shouldn't take more than 8 milligrams on day 1. And remember, each 2 milligram buprenorphine tablet will contain naloxone 0.5.
Okay, no more than 8 milligrams bupe day 1.
Exactly. Then, on day 2, they can start with the day 1 dose up to 8 milligrams, with redosing every 2 to 4 hours with 2 to 4 milligrams of bupe. They cannot take more than 24 milligrams on day 2.
Okay, no more than 24 on day 2.
On days 3 to 7, total day 2 dose. And if they still feel sick, they can take 2 to 4 milligrams of bupe every 2 to 4 hours with a maximum dose of 24 milligrams. It's great if you can remember it, but until then, I would encourage you to review your facility policies and the SAMHSA guidance for induction and maintenance of buprenorphine naloxone.
I just don't see how this is in our scope of practice.
Well, what do you mean?
Well, I'm studying to be a family nurse practitioner. I just don't think that patients like Sarah are in my bandwidth. They're complicated and beyond the services I can provide. I'd refer folks like Sarah out to behavioral health prescribers and a social worker.
I see. What do you think Sarah will do as she waits to be seen by other providers, like a psychiatrist or a psychiatric mental health nurse practitioner? Do you think her use of opioids will decrease? Or is there a risk of Sarah becoming desperate enough to purchase drugs off the street or off the dark web or even overdosing?
I don't know. I just don't think it's our responsibility. That's not the patient group I want to treat.
I hear your rationale for not wanting to treat someone who has a substance use disorder, but I sense there may be more. Here are the reasons I hear from others who would prefer to not treat individuals with SUD. I don't know how. Well, that's a knowledge problem. I don't want to, or leave it to the psychiatrist, the PMHMP, and social workers to figure it out. See, that's an ethical problem. And they're too complex and make bad choices. That may be a problem with misinformation and stigma. There are also our own narratives and experiences with individuals who've used opioids, alcohol, stimulants, tobacco, cannabis, and have crossed our paths in life. Maybe they've been part of our family or patients you've cared for. Those interactions may not have always been positive.
I guess all that fits. I don't know how to treat them. And I suppose I don't want to. They've made their choices and they need to take the natural consequences of those choices. I was in a lot of pain after a patient hit me in the ER. And I didn't get addicted to my pain medications, including opioids. I chose not to be.
It sounds like you have strong feelings about this. I understand. And to be transparent, NP's prescribing medications for OUD is a shift in how we think about offering nursing care at an advanced level. Some of it has been driven by laws, such as the MAT Act, which offers us the opportunity to prescribe some medications for OUD without special registration with the DEA. But this goes beyond policy. Let's talk about choices patients who are diagnosed with SUDs make, and if it's really a choice once our brains turn on to these substances. Let me review with you the neurobiological changes in our brains. Let's talk about the complexity of SUDs as a chronic disease and compare it to individuals with type 2 diabetes. And let's talk about what happens if we don't treat patients with SUDs and OUDs and refer them to seek treatment elsewhere or escalate their use. Last, let me show you some resources to access so you feel more confident in your future practice. Would you be open to that discussion?
When I was an ED nurse, I got slugged pretty bad by a patient who was high. I had to take time off work. I had my jaw wired shut for weeks. But I wanted to be an advanced practitioner so I could have continuity with the patients and provide holistic care. So, yeah, I'll take that information. Thank you.
Great. Okay.
Clarissa and Kaylee continue to talk about Sarah's case and individuals with SUD/OUD. Kaylee admits her anger toward the person who struck her and how difficult her recovery was. Clarissa emphasizes having a team approach to help individuals in recovery, not limited to medical and advanced nursing providers. Clarissa shares a link to the APROUD-MOOC SAMHSA resources and evidence to support how medication for opioid use disorder has been effective in supporting patients like Sarah in their recovery. She shares literature about the opioid crisis facing the United States and globally, and the difference NPs can make.
Hi. Yeah, I just got done. I was at the nurse managed clinic in town. It went well. I learned so much. My preceptor, Clarissa, she's very knowledgeable about treating different types of patients. Yeah, I saw patients across the lifespan, from older adults to younger adults. I even realized that NPs can prescribe buprenorphine. It's for opioid use disorder. No, I wasn't sure either. But it turns out that NPs can treat individuals who need medication for opioid use disorder. It could save lives. Like I said, I learned a lot today. Okay, I'll talk to you soon. Bye.